Hello everyone and welcome to a new session of angina clinical pharmacology question using Bloom's taxonomy. Going to maybe uh, taking a question depends on the Bloom's taxonomy level, and we have remembering, understanding question, applying question, analyzing, evaluating, and the last step will be creating. Okay, regarding the first level of Bloom's taxonomy question, remembering and knowledge recall, which of the following is a short-acting nitrate used for acute angina relief? Okay, we have A, isosorbate dinitrate. We have B, metoprolol. Then we have C, nitroglycerin, and D, amlodipine. And the correct answer here will be nitroglycerin. Okay, we're looking for the short acting here. Nitroglycerin short acting start working in less than 1 minute. Okay. Here, isosorbate mononitrate, this is oral and need between 30 minutes to 60 minutes to start working. Metoprolol beta blocker and amlodipine CCB calcium channel blocker. Okay, next level of the question regarding Bloom's taxonomy for angina, understanding, interpreting the results or information. Why are beta blocker effective in stable angina or angina? A, beta blocker increase coronary blood flow. B, beta blocker decrease myocardial oxygen demands by reducing heart rate and contractility. C, beta blockers cause coronary vasodilation. Or D, the beta blocker, they stimulate nitric oxide release. Okay, the correct answer will be beta blocker decrease myocardial oxygen demand by reducing heart rate and contractility by blocking beta 1 and receptor in the heart. Okay, this will decrease heart rate and decrease myocardial oxygen demand. Someone may argue about nitric oxide. We have one medication may increase nitric oxide, belong to the beta blocker, will be nebivolol. Okay, regarding applying application using knowledge in clinical scenarios, the question here, a 60-year-old man with a stable angina is prescribed sublingual nitroglycerin. What advice should be given regarding its use during angina attack? Number 1, swallow tablet immediately. Number 2, take tablet only after meals. C or 3, take 1 tablet under the tongue at the onset of chest pain. And D, chew the tablet for faster absorption. Okay, the correct answer will be place the tablet under the tongue at the onset of the chest pain. We don't swallow the tablet due to the first pass metabolism. Okay, we don't take the tablet with meal, and chewing the tablet will destroy the effectiveness of the medication. So the correct answer, we give the patient maybe instruction to place the tablet under the tongue at the beginning of the chest pain. Applying. Analyzing the data, analyzing the information, clinical cases here, evaluate lab data. Which combination of drugs is most likely to cause excessive bradycardia in patient with angina? Okay. So you can see here we have nifedipine isosorbate dinitrate, we have metoprolol verapamil, we have amlodipine ranelazine, we have nitroglycerin aspirin. So which of these combination of medication may cause excessive bradycardia? So the correct answer will be metoprolol, verapamil. Metoprolol, black beta 1 in the heart and cause bradycardia. Okay, this is number 1. Then verapamil, black calcium channel receptor in the heart and cause also bradycardia. So you can see here we have excessive bradycardia when you combine these two medications together, metoprolol and verapamil. Analyzing or analysis according to the Bloom's taxonomy. Here we try to analyze the situation. Evaluate based on the criteria and prioritizing treatment. A patient with variant Prinzmetal's angina is prescribed beta blocker. Which the following statement is correct? So we prescribe beta blocker to the patient with a variant angina. We try to figure out, is this maybe correct prescription or something wrong? Number 1, we talk here about variant angina. Beta blocker preferred first-line treatment. Beta blockers are preferred first-line treatment. Beta blockers are or should be avoided due to the risk of vasospasm. C, beta blocker reduce nitrate tolerance. Or D, beta blockers enhance calcium channel blocker action. So the correct answer will be, okay, beta blocker need to be avoided due to the risk of vasospasm. Again, we need to remember that this is evaluation here. We need to remember that variant angina, Prinzmetal angina, mainly due to the vasospasm. Okay, mainly caused due to the vasospasm. And we know that beta blocker increase risk of vasospasm and worse the situation. For this reason, we don't prescribe beta blocker in patients with variant Prinzmetal angina. Okay, creating synthesis, formulating treatment plan here. Okay, developed an anti-anginal treatment plan. So we ask about treatment plan for developing. Okay, for patient with stable angina who cannot tolerate beta blocker, what is the alternative if the patient cannot tolerate beta blocker? Number 1, prescribing propranolol and nitrate. Okay, A. B, use calcium channel blockers and nitrate. C, use ranolazine with beta blocker. Or D, avoid all pharmacologic therapy and recommended surgery. Okay, so the patient here, okay, we don't recommend surgery for the patient. The correct one will be use calcium channel blocker as nitrate here for the patient with angina. So what about here, the A, propranolol nitrate? We don't recommend to use propranolol because the patient maybe present intolerance to the beta blocker. We cannot prescribe beta blocker with ranolazine. Okay, it's not recommended to go the surgery directly. We still recommend pharmacological and non-pharmacological approach for the patient. Okay, this will conclude the angina clinical pharmacology question. Our next session will be focusing on the hypertension clinical pharmacology questions using Bloom's taxonomy. Thank you so much and have a great day.